Dr. Gwin is a non-operative sports medicine physician here at Rothman. She completed her fellowship and residency training at Thomas Jefferson University Hospital and has her medical degree from Rosalind Franklin University of Medicine and Science at Chicago Medical School. During her training, she participated in athletic event coverage at the high school and collegiate level, as well as mass participation events. She's also assisted team physicians in event coverage and training room care for the professional Major League Baseball, collegiate, and high school levels. She's a published physician and holds memberships with professional societies, including the American Society for Sports Medicine and the American Academy of Physical Medicine and Rehabilitation. And with that, we'll go ahead and get started. Thank you, Dr. Gwynn.
Hi, thanks for the intro. So we're going to be trying to keep this general, but going over the basics of PRP. And for part of that, we have to go over the basics of musculoskeletal pain, which is what we're treating here at Rothman. So learning objectives. So hopefully understand the basics of the science behind platelet-rich plasma. Some of the evidence that supports it for specific body parts. We're going to go over three of the more high yield body parts, though it can be applied to multiple different areas and joints. Indications for it, contraindications for it, and what you can expect in terms of outcomes and what the procedure might be like if you were to opt for it. So musculoskeletal pain can kind of fall into, three main categories. Is it degenerative pain from the joint, osteoarthritis, or cartilage damage? Is it tendinopathy or a tendinitis? And tendinopathy, by definition, is just more stress or more load on the tendon than it can recover from over time. Tendinitis, it's kind of on a spectrum with tendinopathy, but that implies a more acute inflammation. Whereas tendinopathy is typically more chronic in nature. And then you can have tears, which are typically more acute injuries, though they can be more chronic with more of a fraying type of tear as opposed to a rupture. Here's a rotator cuff tear. Treatment. So a lot of different treatment options for musculoskeletal pain, and we try to tailor it to you and your specific pathology. So most important thing is education. So what is going on? Why is it happening? And what we can do to prevent it and make it feel better. Exercise is probably going to be one of the most important things across the board for musculoskeletal medicine. And within that is physical therapy, addressing your movement patterns, addressing your mechanics, addressing what led to you coming in with pain in the first place. Activity modification. So typically our goal, especially as a sports medicine doctor, is to get you back doing what you want to be doing. But sometimes in order to do that in a healthy way and prevent further pain or increased downtime, we do have to modify what you're doing in the interim. Modalities, that can be everything from heat or ice. If you've been to physical therapy, sometimes they'll use stim or other treatment options like that. Medications, these are available over the counter. They're prescription medications. It's dependent on your pain, the severity of pain, and also your other medical issues and medications you take. Bracing, depending on the body part, can be helpful. It can either take the load off the area of concern. It can protect the area of concern so it doesn't get re-injured with activity. So that's an important tool we have. And then we get to an injection or procedures, which is what we're going to be focusing on mostly today. And then at the end of the road, there's generally a surgery for everything. So starting to reiterate the importance of exercise as medicine. This is both in general and in relation to rehabbing an injury. Having strong muscles and strong tissues sort of acts like a natural brace. So if your muscles are strong, you're going to be less dependent on your ligaments to hold, your knee, for example, together. In terms of cartilage in the knee for osteoarthritis in particular, it doesn't have a real direct blood supply. So you getting low impact activities helps increase sort of circulation to the area and increase nutrient delivery to the cartilage. And then you get a natural pain relief. So, sometimes people talk about the runner's high. Those are the endorphins that are released with exercise. It also improves to soft tissues, blood flow, and circulation to the area, um, which can kind of help with waste removal, inflammatory removal. Weight management is an important part of everything, especially if we're talking lower extremity. Less weight is less pressure on the joint. Um, the pressure on the joint is multifactorial. So if you have 1 pound on the belly, that can be like 4 pounds of pressure on the knee. And the next thing is flexibility and mobility, especially for the soft tissue structures. If you have overly tight muscles, you're more likely to come in with more acute tendon injuries or muscle injuries. Physical therapy, again, along the same lines as exercise, but this is targeted by a physical therapist who has specialized training and movement patterns and recovery. And one of the main things, especially for the more chronic tendinopathies, is addressing some of the biomechanical issues. So, how you're moving and how your, for example, hip bone's connected to the knee bone that landed you here in the first place. So, working on those mechanical issues for shoulder, postural. I'm usually slouching when I give the lecture about having good posture. So we all do it, and especially with modern society, desk jobs, it can really impact how our shoulders move and pain we develop. Again, mobility, same thing. A lot of us will end up with tight hip flexors or tight hamstrings from being seated all day. So trying to counteract that by doing some daily stretching and mobility exercises. When we're talking soft tissue recovery, the type of strengthening exercises you're doing also has different effects. So, for more acute injuries, typically starting with an isometric um, strengthening, which is basically where you're flexing the muscle in place and holding it there. That can help for pain modulation. And then, typically, when we're getting towards trying to rehab the tendon and go for tendon remodeling, eccentric strengthening, which is basically lengthening the muscle under weight, help encouraging the muscle and the tendon to heal back in this nice linear pattern as opposed to a scarred up pattern. So those are some of the things physical therapy can do. And then they also have a lot of those modalities I talked about earlier. Again, activity modification is going to be very important. If you have an acute injury or if you're in a lot of pain, going out and continuing to beat it up short term is not going to be the best thing for it. Adjusting your ergonomics, getting better computer monitors, so you're more likely to sit up straight, all of those things. Addressing your training load or training patterns, again, to help with those overuse injuries. Injection options. Three main injections. Cortisone, which has been tried and true for years. That is a steroid that we usually combine with a numbing medicine that goes directly to the area of pain. For knees only, there's something called hyaluronic acid. We also call them gel shots or visco supplementation injections. Those are a lubricant injection that can be used for the knee to help for pain related to osteoarthritis. And then PRP, which is what we're going to talk about today. There are other orthobiologics, stem cells. We're not going to touch base on those today, though they are becoming more available now. So what is PRP? It is platelet-rich plasma. And what is that? So autologous, meaning your own blood product, and it's created with concentrated platelets and growth factors that come from them. Platelets are a component of your blood. They're critical for clotting, which is why you'll see patients on antiplatelet medicines after, say, a heart attack. But they also recruit growth factors, which we're needing for the healing response. So just the biology of PRP. The platelets, once they are injected, they are activated and they release a huge number of growth factors. So we're basically trying to take your body's own healing response and stimulate it, kind of put it into overdrive by really targeting directly and in a concentrated way the area of concern. Pain in musculoskeletal medicine is typically from inflammation. And your body's healing response is also inflammatory. So short term, you're going to have this pro-inflammatory reaction, hoping for long-term decrease in inflammation, decrease in symptoms, because we're helping your body sort of heal itself. And then regeneration. So I try to be careful with this. PRP falls under the category of regenerative medicine. I just try to be clear about what that's going to do. So if you have advanced knee arthritis, it's not giving you an 18-year-old knee anymore. If you have tendinopathy or tendonitis, it can contribute to tendon healing. But if you have a tendon rupture, it's not going to bring your tendon from one side and connect it back over to the other side. And again, in general, I always say, unfortunately, like we're not creating, 18-year-old joints, 20-year-old joints. So PRP preparation, what you would expect if you come into the office, you would come in for a blood draw. So we ask you to come in hydrated, plan to be here for about an hour. You come in, we draw the blood. We combine it with an anticoagulant, so the blood doesn't clot while we're centrifuging it. And then we put it into the centrifuge machine. Depending on how much blood we draw, the type of kit we're using, all of those things, you can count on it being in there for like 20, 30 minutes, sometimes more, sometimes less. And what you get out is a very concentrated product of platelets. We're going to get into the two main forms of PRP in a second. But after that, then it's just a relatively straightforward injection. Typically, we use ultrasound guidance depending on the body part so we can best target the disease portion of the tendon or the joint itself. Dosing is very important for PRP and also probably one of the limitations for PRP. So typically in the literature, the evidence is that more is more. The trouble is with most of the kits available today, I can't actually tell you how many platelets we're putting in. I can tell you that we use a kit, that it typically gives 13 to 18 times your body's native platelet concentration. But I can't tell you exactly how many platelets are going in. And that's part of the reason why the PRP literature is all over the place. So all of the kits are different concentrations. So you can get some that are only 2 times your blood concentration, all the way up, pushing closer to 18 or 20. And so again, results are dependent on the concentration, which depends on a number of things. So when we're talking about the two main types of PRP, there's leukocyte-rich and leukocyte-poor. Leukocytes are your white blood cells, and they are important in the inflammatory and healing cascade. So for leukocyte-rich, there, again, we're trying to get those tendons to heal in some form. And so for that, we want extra white blood cells because, again, we're trying to promote that healing response. But as part of that, like we said, pain is from inflammation. So with that, you can expect a bump in pain following the injection because your body's mounting its inflammatory response. So for joints, we're not expecting a healing of the cartilage. We typically use leukocyte poor because it's less inflammatory, better tolerated, and similar outcomes. Safety and limitations for PRP. Generally, the same as any injection. Anytime we go into the skin, there's risk of bleeding, bruising, infection. The main benefit of PRP, it is your own blood and your own good stuff. So we don't have to worry as much about allergic reactions or things like that. Again, one of the limitations I discussed earlier, there's no standardized preparation for PRP, and there aren't even like society level universal protocols for what you do before or what you do after. And probably the biggest issue for most patients is PRP is not covered by insurance and there is an out-of-pocket cost. So this table is targeted mostly at knee arthritis because it is one of the growing areas for PRP. And there are those 3 main injection options. So we're going to discuss the cortisone and the PRP because that can be in a lot of different body parts, and those are the main 2 injections. But the visco supplementation or the gel injections are mostly for the knee. So again, cortisone is a steroid. It's an anti-inflammatory medication that's directed into the joint or the tendon. Visco supplementation or gel shots are high molecular weight hyaluronic acid, which is why we just call it gel. And basically, those are really fat molecules that lubricate the joint, grease the wheels. I say keep the knee happy. PRP, we talked about what that is. Cortisone the main goal is to reduce the inflammation and reduce it quickly. So if you come in today and you're in a lot of pain and you got to go do something next week, cortisone is going to be like the tried and true to get that pain down. Gel, I think about is more long term. It's typically done in a series of injections and it doesn't kick in until you complete the series. So again, I think of that more so as a maintenance injection. And PRP is also targeting more long-term results than cortisone because it's getting your body's own healing mechanisms to come in. It doesn't work immediately, which is where we get to time to feel better. Cortisone, it's pretty quick. Visco supplementation, you have to complete the series and there's some gradual improvement after that. And then PRP, everyone's different. I usually do a phone call follow-up about 6 weeks because that's when I expect to see some noticeable improvements, but you can still expect gradual improvement after that. How long the relief lasts is really varied, and it depends on what you're treating. Cortisone, my non-answer to patients when they ask is I can repeat it in 3 months. That's as soon as you can repeat it. The hope, obviously, with any intervention is you get more relief after that. And that's where some of the other treatment options come into play. Benefits of cortisone, it works quick, it's relatively inexpensive, and if you do have swelling, it can help with that. Gel injections are generally well tolerated, also generally covered by insurance. Doesn't have some of the negative side effects of cortisone, which we'll get to. PRP we're going to get to, but typically better results in head-to-head studies, especially for long-term compared to cortisone or gel. Limitations for cortisone, it's temporary. And the biggest one, the biggest few for cortisone is cortisone injected over and over again starts to wear down the cartilage or the tissue. So you're getting, that short-term improvement for potentially trouble down the road. That being said, I use cortisone all the time. It's a very good tool, especially when used judiciously and appropriately. Another concern for a lot of patients is cortisone is a steroid, and steroid raises blood sugar. So if you're a diabetic, it can increase your blood sugar. For gel injections, they don't tend to work as quickly. Again, we think of them more so as maintenance. A lot of times because it's gel, it's thick, patients feel discomfort after the shot. That usually goes away on its own, but the shot itself can be uncomfortable. For PRP, main limitations, it takes a little bit of time to work, typically not covered by insurance, and results vary. So that's where patient selection comes into play. PRP, in terms of post-injection side effects, it depends on what joint you're injecting versus tendon and how much discomfort. I typically tell patients to expect some discomfort from a PRP injection. The knee shots are typically better tolerated, but especially the soft tissue ones are uncomfortable, unfortunately. And then the other limitation we talked about, there's not a whole lot of standardization kits. So the kit we use might be different than the practice next door, might be different than someone else. And that's where you also see like a lot of price variability in the market. It's dependent on the kits that you're using because that's where a lot of the cost comes from. So now we're going to cover 3 body parts I use it for the most. The number one being knee osteoarthritis. Growing and growing evidence for knee osteoarthritis and platelet-rich plasma. We sort of talked about the limitations of cortisone and why people might want to avoid that. So what is osteoarthritis? That's the wear and tear arthritis as opposed to a rheumatoid, which is an autoimmune type of osteoarthritis or type of arthritis. And it's basically cartilage degeneration that happens over time from wear and tear, from prior injuries, bad luck, mom and dad, stuff like that. And it leads to joint inflammation, which is what causes pain. It can also lead to swelling. So PRP has been shown to improve pain and function in many trials. Again, I want to reiterate, especially for arthritis, the goal is for symptomatic relief and not cartilage regeneration. So osteoarthritis, by definition, is a degenerative disease. So any intervention we do for osteoarthritis, we do expect to have to potentially repeat at some point. So we don't, unfortunately, have any, one injection or treatment where I expect to inject you and never see you again. So they've done multiple meta-analyses, which is where they're comparing multiple different studies across the board, aggregating the data and seeing what they can get from it. And PRP often outperforms the gel injections and the cortisone. I don't have a slide for it, but there's actually growing evidence for PRP and gel in combination. They kind of work at the same problem in different ways that help each other. So we've been getting good results with that. What brand of arthritis makes you a better candidate for PRP? So across the board, people with more mild or moderate arthritis certainly do better with PRP, and the delta, the how robust the response is between PRP, cortisone, and gel is also bigger at the lower arthritis levels. That being said, people who have minimal arthritis also tend to respond to a lot of stuff. As arthritis gets more advanced, there is still a benefit of PRP compared to the other two, but that difference kind of decreases. There was one study that did show once you get to bone on bone, PRP might still have a little bit more. It might still be slightly more effective than, say, cortisone, but typically once you get to bone on bone, it's a wash in terms of improvement following an injection. The big thing is if you get to bone on bone and your knee starts to develop a deformity, so you're kind of like tilting to the side, knock-kneed, or bow-legged, then there's really no difference. And for the cost associated with PRP, we typically wouldn't recommend it. Tennis elbow is another one of probably the better studied areas for PRP. And what that is, it's wear and tear on the tendon over time. So tennis elbow is the outside part of your elbow, and that is in theory from hitting a backhand in tennis, where your wrist is kind of extending back repeatedly. But we also see it from computer use a lot. Any repetitive fine motor thing can lead to it. And what is the evidence for PRP for tennis elbow? There's long-term improvement in multiple different reviews. Again, the goal is to decrease the pain and increase the function. We do expect some tendon healing, but again, if you have a big tear, it's not attaching those pieces to each other. The success rate in the literature varies pretty widely, anywhere from 36 to 100. I'm not sure I believe 100%. And I believe that was a smaller study, right? So if you only test 5 people, you can get 100% pretty easily. But if you test 1,000, it's less likely to happen. Though, as I talked about earlier, is a limitation. And some of the trouble with the literature is all the kits are different, all the concentrations are different, and the makeup of the PRP is different. So if you use the leukocyte-rich PRP, the one I was talking about for tendinopathies, that success rate, which is typically measured in pain scale outcomes and functional outcomes, which are standardized for medical literature, that success rate can increase from 70 up to, again, that 100%, which, again, I would probably say that maxes out at high 90s. 100 is a very lofty goal. Rotator cuff tendinopathy is another one. Again, rotator cuff injury is on a spectrum, right? So is there some slight fraying of the tendon? Is it tendinotic, which is where the tendon isn't nice and linear and it's a little bit more kind of scarred, to small tears of the rotator cuff, to complete tears of one of the tendons. There are 4 rotator cuff tendons, to a massive tear, which is where you have multiple tendons torn. And obviously for the massive tear or complete tears, those are usually something that are addressed surgically, because PRP, again, one of the big take homes I want is I would think of it as symptom management. So we are hoping for healing for tendons, but the goal is symptom management. So it's not something where we bring you back and we get another MRI and see how much the tendon is healed or look for changes. For us, success is based on how you feel and what you're able to do, what your limitations are. So this is tendonitis, where there's a little bit of change to the tendon versus a complete tear or rupture. So PRP for rotator cuff disease, again, it's a lot of patient selection, and results can be mixed. But you can see improved pain 30 to 60% of the time, improved function 20 to 50% of the time. And again, that's where patient selection is key. So those numbers should go up if you're picking more appropriate patients and doing the appropriate rehab that comes with it. Um, so to reiterate, what PRP cannot fix. So complete ruptures. I think I've said that a couple of times. So if that didn't get through, I've messed up. Any severe deformities, bony malalignments, stuff like that. And once you get to bone on bone arthritis, it really is a toss up whether or not it's going to be helpful. And when you have to factor in price and the time it takes to get the injection and the setup and all of that, it's typically not recommended for bone on bone. But because of the low side effect profile, sometimes patients do try it and they can get relief. So contraindications are similar to any other injection. So if there's an active infection in the area, certainly if you have a skin infection, we don't want to introduce a needle, introduce bacteria into the joint, which can create a problem. Anemia, so blood kind. We are doing a blood draw to do the injection. So uh, if you're anemic, we don't want to be taking more blood out of you. Certainly platelet disorders, so issues with platelet clotting, low platelet count are all reasons we might pause before performing PRP. If you're on antiplatelet medications, especially if it's related to a stroke or a heart attack, say you've had a stent, those are not medications we can stop. And uh, we don't want to be injecting platelets that we're also intentionally giving you a medication, so they won't work. And then cancer concern is, theoretical risk for metastasizing anything. And then also it can lead to the growth factors help with angiogenesis, which is creating blood flow, which provides nutrients, which could in theory feed something. So post-procedure expectations. Again, you come in, you get the blood drawn, and we perform the injection in clinic. Again, typically under ultrasound for the tendon issues and for the larger joints. A little pain associated with the injection itself. Tendons, because you're going straight into the tendon, the disease portion of the area, and you're inserting a pro-inflammatory injectate. The injection itself is going to be uncomfortable, and we do expect a bump in pain for about 3 to 5 days. The healing is not going to be a light switch. The goal is, after that initial inflammatory phase, when you calm down, get kind of to your baseline level of pain, over the next few weeks, you're going to see gradual decrease in pain. And then we do restrict, I do restrict activity following the injection. So I think we'll get there. So after PRP, we'll restrict activity. For most people, for most joints, I'm restricting it for about 2 weeks. So even physical therapy, I'll hold on for about 2 weeks just to let the medicine get in, let the body do its thing without kind of irritating it in the interim. And then physical therapy, I strongly encourage, especially for tendon related issues. They will basically do progressive loading on the tendon or muscle and a structured therapy protocol. They can use some of those modalities, but the idea is help your body heal itself in an organized fashion to get more longer lasting results. So the biggest thing is, any intervention done in isolation. So you just come in for a one-time thing and then you go away, don't do anything else. Those are, rarely successful. So the best treatment plan is one tailored to you. PRP can be a very helpful tool. But if you just do the PRP and don't do the rehab or go out and beat it up the next day, the efficacy is going to be more limited. You know, the results and the efficacy are individual, and that's where patient education is really important. Working with your physician to discuss whether or not you're a candidate is very important. Some of the big benefits are, the side effect profile is very good. So again, cortisone we use all the time. I do not think it is a bad medication by any stretch, but it does have some downsides. And, for those, that's where PRP thrives. And again, it's hoping for longer term symptom relief. And again, the takeaway for PRP is I want you to think symptom management over like tissue regeneration. So our goal is to get your symptoms down. We don't follow imaging studies to see if it's improved because um, truthfully from our end, if you're back doing what you want to do and your pain is down and you're sleeping at night, it doesn't matter to me what the tendon looks like on an MRI. And I think the other thing back to expectation management is what do I consider a success versus what do you consider a success? So if you come in and you say, hey, my pain's down like 70%, I might be really happy with that, and you might be pretty disappointed with that. And that's where putting the whole picture together with what exactly is going on with your injury. Um, what can we reasonably expect from an injection coupled with a rehab program? And uh, what does this look like moving forward for you? These are some of the references. I got a longer list somewhere, but that um, is kind of PRP in a nutshell.
Hi, sorry, my mouse wasn't working. Okay, so we do have some questions in the chat. I've seen this one a couple times, so we'll just, oh, my video is still not working. There we go. So we'll just start with this one. In terms of cost, does insurance cover it? And if it doesn't, what is the cost?
So I can tell the cost at Rothman. It's $995. It might be $999. It's basically $1,000. Typically, insurance does not cover it. That's the most simple explanation. It doesn't cover it.
Okay, simple. Um, can the process be done with a patient on blood thinners?
So antiplatelet medications. So you can do it on anyone, right? It's just will it be effective? Which is I'm assuming what you're asking. So anyone on antiplatelet medications, which would be like a clopidogrel or full dose aspirin or something like that, I don't recommend it because those are typically impacting platelet function, and the whole point is using your platelets. On blood thinners like a warfarin or an Eliquis, it's more of a gray area. It can be performed, though. We do use. Um, it still is your blood we're taking, so it's like a soft contraindication.
What is your opinion on the particulate form of amniotic umbilical cord tissue instead of PRP, and have you used this option?
That is loaded. There is growing evidence. Um, Uh, we don't use it here. I'm not sure you can use it in the US outside of uh, trials, depending on what exactly you're referencing. Some of the benefits of that is one of the drawbacks of PRP is, like I talked about, I can't tell you exactly how many platelets I'm giving you. I can tell you, like, hopefully it's a lot, and what it should be compared to normal blood concentration and all of those things. But some of the amniotic tissue, we can know exactly what we're injecting you with, which that's very promising. Um, but yeah,
So where are they getting that? Or like people donating it after they give birth?
uh, yeah, that's where they get them. There's something called Wharton jelly, which is like in the umbilical cord.
Oh, okay. Um, you listed relief lasting 6 to 12 months for PRP. If it results in a healed tendon tear, wouldn't the relief last forever absent a new injury?
Yeah, I think that was in the table, which was like I kind of designed more for knee arthritis, which is a degenerative thing, which we expect to have to repeat. Um, but yeah, so and that's where expectation management is really important. So osteoarthritis, we expect to have to repeat it at some point. And whether that be 6 months, 12 months, 24 months, more, hard to say. For tissues, especially ones without like severe damage, the hope would be you get a PRP injection, you do the rehab, and you're good.
How frequently would you need to do these?
So there are different protocols everywhere, which is why in the literature you'll see those percentages vary pretty widely. Um, one protocol that was initially developed, typically that was with much lower concentration kits than we use in our office. So again, you can get some kits that are only like 2 times your native blood concentration. And people will do like 3 injections a week or 2 weeks apart, trying to boost that. Versus our kit, the one I use is up to 18 times your blood concentration. So I plan to only use 1 injection for that. What was the rest of the question? Sorry.
Oh, it was just how often do you, hang on, let me pull it
Do
up.
them.
Yeah, how often would you need to
So
redo it
yeah,
for
typically my
maintenance?
plan for most injections would be a one and done with an occasional. Sometimes at that 6 week appointment when I check in with patients, they'll say like, "Hey, I'm like 65, 70% of the way there. Like, I wonder if I can get a little more." And I might do a top off injection then. Um, but typically after that, it's not something I would expect to have to repeat frequently. But it is dependent on your pathology.
Great. I have a couple research questions. One, are you collecting data for research? And the other is, are you using it for the spine or researching the use of PRP for the spine?
Um, we are doing multiple PRP studies at Rothman right now. They're not randomized controlled trials, which are the gold standard. Those are a little bit more difficult to do for something like PRP. Um, don't Not a lot of favorable stuff for the spine in PRP right now. In my division, we're not actively researching. I can't speak for the spine like surgical team. Um, yeah.
Okay. Why is leukocyte pore better for joints when trying to heal cartilage?
So that's where the kind of so for joints, for cartilage, on the like micro level, you can expect a little rebuilding of the cartilage matrix, but because of the lack of blood supply to cartilage and the nature of the cartilage versus a tendon, we're not really expecting healing. I'm expecting your body's um, healing responses to bring down your symptoms, but I don't expect it to like repair cartilage or put it back together. And so then why inflame you if we can use the other components uh, of your plasma to get it to feel better?
Um, they offer chondroitin, MSA, and hyaluronic acid. The results in literature are mixed. What's your opinion?
So, um, I mean, viscosupplementation injections, the gel shots we use in this office all the time. Anecdotally, we have a lot of patients who get very good relief and have been getting good relief for years. That being said, the literature for that uh, isn't that strong. And that's why some insurance companies are starting to give us a harder time about injecting it. Again, anecdotally, we all see excellent results all the time. That goes back to patient population. With chondroitin, less literature to support that than the other stuff. They're all tools in our tool belt, and it's patient dependent, like what your goals are, what your comorbidities are, all of those things.
How are symptoms diagnosed since, and then once a specific diagnosis is made, is that when you decide the best treatment?
Yeah. So clinical history, physical exam in office, imaging, like typically MRIs. We do use the ultrasound to direct the needle, but I typically like MRIs to give you a full picture of what's going on.
Is the plasma that's collected able to be donated?
No.
Okay. It says, is it true you said PRP is not really an option for knee for an active person in their late 60s with bone on bone or moderate osteoarthritis and a mild bow leg who's already tried cortisone and gel shots?
A little specific.
Very specific.
So it depends on if you're bow-legged because that's how you were made, and if you're bow-legged because you're so bone on bone. So because you said moderate and severe, right? So if you're moderate, my favorite thing for PRP right now is it's typically like 40s, 50s, 60s, active with a bum knee. That's my favorite thing. That's the best results I'm getting consistently. So I mean, depending on what that bow leg and the bone on bone bit, you sound like a good candidate.
Great. This one I got via email. There's four questions, but I think I can condense it. I guess they want to know the procedure. Should I get an appointment prior to analyze the issue, or is it all done in one visit? This person's not able to get an MRI, so do you have to be able to get an MRI to do this? And is this all done in one day? Can they draw the blood and do the injections on the same day?
So it's not same day. I forgot knees, the one area where I don't get MRIs. The MRIs are really more so looking for tendons, right? Because if you have a complete tendon rupture, PRP is not going to be helpful, and you probably need to see one of my colleagues. So I think the consultation appointment is very important. I have some protocols. Again, you're using we're using your platelets. So I ask you not to take anything that can inhibit the platelets before or after the injection. So going over all those sorts of things are important. Letting you know that there's going to be pain, letting you know that I don't want you to be active. So I don't want to do a PRP injection and then, you have the marathon next weekend. So I think that initial appointments are important for all of that. And then just, yeah, logistically, you can't do it same day because it's a longer appointment.
Right. Can you comment on, now I don't know if this is misspelled or if I just don't know this word, Traumeel, Traumeel injections?
I'm actually not familiar
Yeah.
with that.
Okay, I don't know that one either. And what is your opinion regarding PRP for nerve pain where the tendon may be involved?
I'm not sure what exactly that's getting after. So there's like nerve pain because a nerve is pinched. Um, so you can do something called like a hydrodissection where you're basically putting the medicine around the nerve to like make more room and let it calm down. So there's growing evidence for that. I'm guessing that's what you're talking about versus like referred pain, which is where your rotator cuff is at your shoulder, but it actually gives you pain down your arm.
Hmm.
That again, we're treating the rotator cuff and it can be good for that.
Um, how can we contact you? So, if you'd like to schedule an appointment with Dr. Gwin, you can email me directly, and I will get you set up with an appointment. And I know we do it in Marlton. Do you know where? Do we do PRP anywhere else? Do we do it in Pennsylvania at all?
Mhm. Yeah, the so it's mostly my team, the non-operative sports, because we do the
Hmm.
most with the ultrasounds, but some of the surgeons do it too. In PA, I know Phil Motley's doing it. John Luksh is doing it. He's out in Mainline. Phil Motley's,
Mainline, yeah.
yeah, more close to Center City. That's just off the top of my head.
So we're doing it in a bunch of offices in
Yeah,
Pennsylvania,
that's
New
a
Jersey.
faster answer.
So if you want an appointment, they can kind of guide you to the right place
Yeah,
depending on where you
exactly.
live. Um,
Oh, Steve Stash is in King of Prussia. He's a big one.
oh, love
Forgot about
Dr.
him.
Stash.
Yeah,
Okay.
he's my boss, so I'd get in
Oh,
trouble.
you too. Yes, I know you do too. The first step, yes. So the first step would to be reach out for a consultation. You want to have that initial appointment and make sure you're a candidate for that. And if not, maybe something else would be appropriate. So, like I said, you guys all should have my email. I've sent a bunch of emails, and my phone number. So please just reach out to me directly, and I can get you set up with an appointment with Dr. Gwynn. Okay. Wonderful. Well, thank you. Thank you. This was really informative. I didn't know anything about PRP, so this was super informative for me. And I hope it was informative for our guests. Thank you so much. I really appreciate your time.
Thank you, everyone. Thank you,
Alrighty,
Kristen.
have a good one. Bye.
Bye.